Terrific. Thanks you. Thank you, Vivian. So I welcome you to this month's iteration of the DC CFAR Global Scientific Interest Group. For those who are new to the group, particularly the presenters, the CFAR stands for the Center for AIDS Research, and it's secretariats at George Washington University. And this is there are several scientific interest groups, and this is one of them, focused on global issues and intersecting global and US-based domestic issues. Next slide, please. We have just a few slides introductory for those who are not familiar with the group to become familiar. And here we have photos of the 4 members of the team, which bring these sessions to you. First, let me start on the right with Vivian, who was just saying she's starting the recording. She is all things organization. You need to reach out to her. She organizes all of these meetings, so thank you very much, Vivian. Khadija in the middle is our community lead, and she had a personal emergency today, so she won't be able to join us. Myself, based at Population Council and George Washington University, and joined also by my co-lead, Natella Rachmanina, who's also on the call, based at Children's Hospital. Next slide, please. So our overarching goal for this group is to be a platform, as the other scientific interest groups are. So a platform for collaboration across colleagues, across the network of the Global SIG, across the network of the DC CFAR and others, also to help support capacity and sharing best practices to improve HIV outcomes amongst the local and global issues, strategies and methodologies, what we can learn back and forth from each other. And the DC CFAR includes academia, community-based organizations, and government. And so many of us are collaborating across, including with community-based organizations here in the DC area. The CFAR investigators, the networks across the CFAR, I mentioned that we're the DC-based CFAR, but I think there are 19 CFARs across the United States, as well as global partners. And the underlying goal is to bring lessons from our global work in a number of different settings, particularly community-based settings and facility settings, to think about how they might be applied in the US-based settings, and also vice versa in the other direction. So there's a lot of opportunities for learning across. Next slide, please. And here we have our agenda for today. I'm Dr. Julie Pulowitz again, and we're going to have a presentation from 2 colleagues, one based at American University, which is part of the DC CFAR Global Network, on Dr. Nicole Angotti, who I'll be introducing in just a moment, and Dr. Xavier Gómez-Olivé, who he just spoke a moment ago, from the University of Witwatersrand, often called WITS by those who work in South Africa. And then we're going to have a discussion moderated by Dr. Natella Rachmanina, who I just introduced. So perhaps I will turn to the biographies of our speakers, and then we'll get going with their presentations. Great to see you all here. So Dr. Angotti is an associate professor of sociology at American University, as well as associate director of AU's Center on Health, Risk, and Society. So her research focuses on population health and medical sociology, and addresses cultural, social, and institutional dimensions of health and well-being, with a long-standing focus on the HIV epidemic in Southern Africa, and they'll be talking about that today. And our other colleague today, Dr. Gómez-Olivé, is an associate professor and the associate director of the MRC WITS Rural Public Health and Health Transition Research Unit at the University of Witwatersrand. He's both a medical doctor and an epidemiologist, and he thinks about health systems research, particularly adolescents, HIV prevention and treatment, and mental health, and a number of other issues. So Dr. Angotti is a principal investigator with Dr. Gómez-Olivé of an R21 funded by NIH that they'll be talking about today, entitled Intergenerational Intervention, Employing Youth to Promote Aging Healthy with HIV in Rural South Africa. So I won't describe the study because they're going to be able to describe it themselves. So I welcome you both here. Thanks so much for being willing to present to the group here. And I turn it over to you.
Well, thank you so much for that introduction, and to all of you for being here. This is really exciting. Just give me 1 second so I can make sure my screen is being shared properly. Okay. You seeing just the slides, not the presenter view? Yeah, okay. I see Wendy nodding, so I'm going to take that as a universal yes. Anyway, yes, so thank you all again for being here, for this invitation to present our work that begun with generous funding from and support from the DC CFAR Pilot Award. And now, as Dr. Pulowitz mentioned, is now grown into an R21 award, which has been funded by the NIH through the multidisciplinary studies in HIV and aging PAR. So that work is building upon the Pilot Award study in key ways, which we're going to be discussing today. So I'm going to actually, I'll be presenting the work on behalf of our team, and for Xavier, and Xavier will join us for the Q&A afterwards. Okay, so let me start. I wanted to start us off with some background about this study. So this study began with a fundamental concern about the growing population of older people in sub-Saharan Africa who are aging with HIV, and who are also a growing population with suboptimal HIV-related outcomes. South Africa in particular, as many of you know, bears the world's largest HIV burden. So nearly 8 million people living with HIV. It has a rapidly aging population, which produces a concomitant rise in levels of disability and chronic disease. And the proportion of HIV-infected people over the age of 50 is expected to increase substantially in the years ahead. And so in the study site where our work is based, which I'll describe shortly, and cross-sectional analysis of the HIV care cascade, as you can see from these slides. Actually, do you see yourselves or do you see the slides? That's my question.
I see the slide.
Okay, so you don't see, okay, because I see tiles of you all, and I want to make sure it's not covering anything. Thank you. So what you can see here in this figure from cross-sectional analysis of the HIV care cascade is that the UN AIDS treatment targets of 90-90-90, or I think now the more ambitious 95-95-95, are not being met. So this is analysis conducted by Rohr et al., of which Xavier was part of that study and this analysis. And what we can see from this figure is that based on survey data from the Health and Aging in Africa, a longitudinal study in South Africa, data is that among those aged 40 plus, only 50% of those that are HIV positive are virally suppressed. So attrition throughout this cascade really highlights the need to identify and to bolster the support systems and services that older people living with HIV need to age healthily. Yet HIV care and treatment interventions in sub-Saharan Africa are not explicitly targeting older populations. We know, there we go, that HIV care has long relied on supportive household and community resources, particularly in settings with few human resources for health. And that without alternatives to family-based care, most older Africans age in place. But because of with high rates of labor migration and earlier AIDS-related mortality, a lot of older Africans may be aging without the support of their adult kin. And so there's maybe a need to look elsewhere to seek the multidimensional support that might help older people to age healthily. And so what we sought to do broadly in the Pilot Award was to understand how household and community-based support either bridge or complement health services for HIV and health management among older adults. So what we had originally planned to do with this study were in-depth interviews with older people living with HIV and their household members, alongside extensive observational methods focused on daily living and the routine self-management of health. But at the same time, we were beginning our field work, the COVID pandemic erupted. And so not only did it present us, as it did all of us, I'm sure here in the room, with some serious challenges to data collection, which forced us to rethink our approach, other salient and important issues also emerged. So one is that we saw increasingly challenges older people faced in getting into health facilities. So there was drops in clinic attendance. But we also saw a rise in youth unemployment, which was already a national concern in South Africa, but it reached a peak in our study site at the height of the pandemic, with 75% of labor migrants returning home unemployed. So, these statistics obviously looked quite bleak, but at the same time, we also saw stories emerging in South Africa and actually on both sides of the Atlantic of youth assisting the elderly in very kind of inspiring ways during the pandemic. So, for example, we saw youth in South Africa, initiatives helping the elderly with vaccine registration. And even here in the DMV, high school students, I'm pretty sure in Montgomery County, were delivering food to the elderly at the peak of quarantine. So we were presented with this opportunity to think about how youth might help fill support gaps to assist older people in their communities to age healthily with HIV. And at the same time, that providing that care could offer them meaningful employment. And so, returning back to our broader study aim, not only did we want to learn more about the role of households and communities, resources in supporting older people to manage health and HIV, we wanted to know if there might be a role for youth to play in fulfilling existing support gaps. So let me take you virtually to South Africa, which might be a site that many of you in this room virtual room are familiar with. So this is a map that might be familiar. Our study is based in the Bushbuckridge sub-district of Elanzeni district in Mpumalanga province, which is located in the rural northeast of South Africa. It's about 500 kilometers from Johannesburg and borders Mozambique. The area is a former apartheid-era homeland, which was one of the inhospitable areas of the country to which Black South Africans were forcibly relocated. And the area remains burdened by the legacy of policies that created poor communities and created weak health services. The primary ethnic group is the Amashangan, and the local language is Chitsonga Shangan. So the study, our study is carried out specifically in the Agincourt Health and Demographic Surveillance Site, which is run by the University of the Witwatersrand, also known as WITS. Since 1992, the AHDSS has collected census data on socio-demographic events, so births, deaths, migration, but also health data. Across an area that currently covers 31 villages and a population of about 116,000 people living in 22,000 households. And for our purposes here, the Agincourt Health and Demographic Surveillance Site also hosts numerous quantitative and qualitative projects that can make use of the census as a sampling frame, and which benefit tremendously from the site's research infrastructure and ongoing and strong ties to the community and local leadership. So a few other kind of important things to mention about the context. So there are 7 clinics, which this map is showing in the study area. Antiretroviral treatment was available at hospitals in the area in 2005. It expanded to 2 health facilities in the study site in 2007, and it became freely available in all 7 of these health facilities by 2012. In 2016, South Africa adopted universal test and treat policies. So as you know, with universal test and treat, all those who are testing positive for HIV at a health facility are immediately started on antiretroviral treatment, regardless of their viral load status. The second point I wanted to talk to you about the context is the role of social grants. Since the democratically elected government in 1994 under Nelson Mandela came the introduction of, under his leadership, of social welfare grants and programs that became available to, among other groups, older adults. So older people now have been or are able to receive pensions, which are means-based, non-contributory pensions, and which in our study site are a critical source and household resource. The third is about levels of education. So among the older population in South Africa, again, is a legacy of policies under apartheid. Only half of the older population have formal education, and another 30% only have some primary school education. So in some, 80% of the older population have either no formal schooling or just primary schooling. Okay. So as part of the DC CFAR Pilot Award, we conducted community focus group discussions with older African women and men aged 50 plus to learn more about the role of households and the community and the management of health, including HIV, among older populations. And we conducted 12 focus groups total that were stratified by older age group, gender, and village area. We recruited participants. Our study team recruited participants by visiting the homes of where they knew an older person was living, and then asked that person if they would bring 1 to 2 people their same age and gender to the focus group if they were interested in participating. Broadly speaking, the focus groups, we focused on topics including growing older, the experience of growing older. We discussed existing health-related support to older people, including for HIV, the normative expectations of youth in the area, as well as how their responses to the idea of youth as support and caregivers. Our data were collected by a study team from the Agincourt Health and Population Unit, who are from the study area. And so the focus groups were conducted in the local language in Chitsonga Shangaan, and then translated and transcribed into English by the local study team. So in total, our sample included 86 participants with an average age of 64.7 years old. All right, so a bit about the analysis. The focus groups were analyzed utilizing thematic analysis techniques following recommendations by Braun and Clark. And this is an iterative process consisting of a series of steps, including becoming familiar with the data, generating codes, generating themes from those codes, reviewing the themes, defining and naming them, and then locating exemplars in the data. So our analysis was conducted through a sort of team coding approach with 3 members of our study team. And we took steps to ensure inter-rater reliability, including analyzing the same subset of transcripts, discussing the emerging meaning of codes, refining the meaning, and then agreeing upon them before dividing the rest of the transcripts among the group for independent coding. And as you can see here from this table, we generated 7 main themes, which I'll now discuss in turn. So the first theme focused on aging was really about the process of advancing in age or growing older over time, including kind of physical, psychological, and social changes that occur as an individual progresses through the various stages of life. And some of the findings from the analysis of this theme were related to, that sort of came up, was a lot of comparison between the then and now. So those of us who conduct research on aging are very familiar with this sort of nostalgia that emerges in these discussions about differences between, what life is like now versus what life was like then. And so in some ways, there's a real sort of romanticism for an easier, for what the past was like. Much of that though, was related to this experience of new illnesses and chronicity, what in the local language is referred to as mavabzi yamasiko lawa, which translates broadly into nowadays diseases. So this sort of constellation of illnesses that are new and that weren't, there before. Illnesses that emerged because of, the way food is now purchased rather than grown, for example. And obviously, HIV falls into that constellation as well. There was also a lot of discussion about the way that the cultural expectations around care have changed, and discussion as well about this mistreatment by younger generations and a lack of assistance from families. So as you know, one participant noted, to grow older, it's painful. There's no more joy. Even your grandchildren are no longer coming close to you. They're afraid because you will tell them to do something for you and they will hide. There was also talk about, the concern that their old age grants are being spent on their families. Again, as I mentioned, the old age grants, particularly multi-generational households, but those receiving the grant, older people receiving the grant become the sort of breadwinners of their households. And but there was also talk about how the need to feel as though they could be role models for the next generation. The second theme was related to existing support for older people. And, what we learned was about the role of home-based care. Well, we heard from them about the role of home-based care organizations, as well as the role of the church. And as we can see here, as one participant noted, we do see home-based care organizations when it comes to support and care. They do help children that have no parents, and they also help older people by giving them food and collecting their medication in the clinics. They also give them clothing. And we also see some churches, they help people that are in need by giving them food parcels and clothing. Participants also talked about help from traditional healers, from Wits University, so research projects, which other studies have shown how, settings with large health research infrastructure can actually be a source of support as well. Government grants as well as relatives. Onto the third team of tasks older people need assistance or support with. Much of this was related to health, so transportation to clinics, collecting medication, as well as health education and concerns about the long wait times at the clinics. There was also mention of assistance needed at home with things like gardening, plowing, cooking. Emotional support came up, so someone to talk to as a way to, avert loneliness, and then additional support, financial support. So as we can see here from two participants, if people from home-based care can regularly visit most of those who are living alone, that would be great, and they should ask them what it is they need assistance with, because obvious they are in need, but for those of us living with children and a wife, we're much better because they are able to assist us. Or as another participant noted of her own experience, the government, I think they should hire people that are going to come to our household and give us our medications. And if they deliver this medication, they should also remind us on how to take that treatment. And it should also be written on the package that the pills you should take, it's for 3 times a day or for 2 times a day, because the money that we're getting for this grant is very little and food is very expensive. Sometimes I even skip my day to go to the clinic because I don't have money to pay for transport. And when I get to the clinic, they don't care that I'm an older person and I have to queue as others, and I will just get my pills later. All right, so moving on to the last 4 set of themes, we also talked about support that they believe youth could provide. And what came up here was very interesting kind of age and gender distinctions, and which circumscribed the set of tasks that they thought were appropriate. So for the youngest young, ages 15 to 24, there was a sense that these youth were too young, but they did see roles that they could play, such as reminding them about medication, bringing them food, serving as their messengers. Whereas the youth that were a bit older were seen as more mature and can perhaps serve as their advocates. So as one participant noted, no, to take care for the older people, they cannot be 15 to 24 because sometimes they will find me naked and won't be able to bathe me, and they are still young, and they will still go around talking about me because they're still young and too young to keep confidentiality safe. Thank you. There was also tasks around gender lines that were clearly distinguished. So tasks that were seen as more appropriate for men, which were external to the home, versus tasks for women, which were seen as appropriate internal to the home, and very much aligned with sort of normative gender expectations. And then other tasks they noted would help with WIS literacy, things like reading medicines and health knowledge. We also asked about any concerns they might have about youth as providers of care. And if there was a discussion about, concerns about the lack of respect that young people are exhibiting towards the older generation, towards a disregard for culture and important traditions. They discussed the unhealthy habits of young people, notably drinking and drugs, and really noted the concerns that they had about youth unemployment, and that youth unemployment they saw as the reasons why crime is so bad in their communities. So as one participant noted, our kids have drawn into drugs, they drink a lot, marijuana, and all those things. There's no more kids who slept at home. And if Friday comes, they went to the taverns and come back in the morning. When they're at the taverns, they fight, they even stab each other with bottles. They don't maybe have good group discussions or think of starting a business that they will get money. And a lot of people are just staying at home and doing nothing. And at the end of the day, they will turn to become criminals because they are jobless. Jobs are scarce nowadays, and a lot of our kids are just staying at home. So the older participants also talked about qualities youth need. So as caregivers, so patience, a good heart, being hard workers, being educated and literate, and also the importance of confidentiality. So one suggestion would be that, if they were to be, providing help and support, they should come from another village in the community. But I should note, despite these concerns, there was overall receptivity to the idea of a young person as a caregiver, with these age and gender considerations, in keeping those considerations in mind. With respect to HIV, participants talked about how it would be important to disclose HIV status, and they mentioned this primarily in the context of concerns about caregiving transmission. So they thought young people can protect themselves, for instance, by wearing gloves if they were being cared for by a young person. And this, very much maps onto, perceptions about the probability of caregiving transmission as a probable mode of HIV transmission, which is, to this day still considered, a prominent form of transmission in the community. But importantly, for our purposes, what we noted were that confidentiality concerns with respect to HIV did not stand out as distinct from confidentiality concerns more generally about any other health condition. And so as one participant noted, I would never have any concern because nowadays people have knowledge about HIV and each and every person is living with it and is no longer scaring. The scary illnesses are sugar diabetes and others. I won't have any concern if they hire a young person for me who will help me and do exactly what I want. No concern at all. Okay, so as I mentioned before, the Pilot Award set the foundation for an R21 submission, which was funded last year. And we just learned yesterday was awarded funding for year 2. So I'm very happy to be able to share that with this group. And in the R21, we build upon ideas and expand the direction of the work that began in the Pilot Award. And so this project in the R21 is called Intergenerational Intervention, employing youth to promote aging healthy with HIV in rural South Africa. And so what I want to do here is kind of highlight some key findings that stood out from the focus groups funded by the Pilot Award that will that is informing next steps with the R21. So in the focus groups, we learned about community support, that home-based care organizations are providing care, delivering medication, checking on people, and so forth, but that care they're providing is either not enough or it's not reaching everyone. In terms of household support, residential family members are an important source of care and support to older people, but not to everyone and not in all households. In terms of receiving health-related support from a young person, older adults do not have concerns specific to HIV. Rather, confidentiality concerns were about any health condition. And finally, despite concerns about youth more generally in terms of their values and influences, they were generally receptive to the idea of youth as support givers with noteworthy age and gender considerations, which would circumscribe those tasks. So what this means for us in terms of next steps is to think about things like How do home-based care organizations identify older people in need of services, and who might be left out? Which household structures or types are most in need of external assistance or more vulnerable to poor health or HIV-related outcomes? And can household support also be external to the family? Also, are older people who are actually living with HIV also amenable to support from a young person in the community? And what are their concerns and considerations, if any? And are young people interested, finally, are young people themselves interested in this work and providing support to older people living with HIV? And if so, for which tasks, and what would their concerns and considerations be? So just to sort of introduce you to what we're doing now with this intergenerational intervention project funded by the R21, is that we're exploring how an innovative intergenerational intervention could improve approaches to the management of HIV and related comorbidities among older people living with HIV, while offering opportunity to the younger generation in South Africa, right, where youth unemployment is a national concern, by employing youth to assist older people living with HIV in their communities. So to shape this sort of this is exploratory to shape early intervention development, what we're doing is a formative and sequential mixed method study with the following aims. So the first aim, we're identifying the determinants of social support that are associated with aging healthy with HIV by gender and across the later life course, focusing specifically on 3 outcomes: viral suppression, management of multimorbidities, and life satisfaction, and how that support is moderated by household structure and composition. And we're doing this through longitudinal analysis of existing quantitative data from the Health and Aging, NIH-funded Health and Aging in Africa, longitudinal study in South Africa, which has been ongoing in the Agincourt HDSS for over a decade now. And in that study, there's a sample of 862 people, older people living with HIV. And then in aim 2, we hope to elucidate how social support gaps can be strategically filled intergenerationally and inform a feasible intervention using qualitative data collected with key intervention stakeholders. So this includes in-depth interviews with older men and women and their household members, interviews with key informants from the health sector and from village-based leadership, as well as focus group discussions with youth. And the study will conclude with a stakeholders workshop to discuss key findings and sort of collectively consider design elements of the intervention, which could then be tested through an RCT study design. So analysis, in terms of where we're at with the project, I'll just briefly explain. With aim 1, we've begun investigating the association between household dynamics and social support in promoting aging healthy with HIV by gender and across the later life course using the HALSI data. Very preliminary findings. For older women, those living in complex cross-generational households are less likely to be virally suppressed compared to those living in other household configurations, and that for older men, those with any social contacts outside the household are more likely to be virally suppressed. And we'll continue to investigate this further, and also continue to explore the influence of the household composition and dynamics on our other 2 outcomes, so management of multimorbidities and life satisfaction. And then with aim 2, phase 1 is actively underway. With key informants, we've now mapped and developed a database of individual informants and organizations from the health sector, from local leadership, and interviews have been underway for the past couple of months. And next month, we're in the process now of gearing up for training and field work for the next stage, which will include the in-depth interviews with older people and their household members, as well as focus groups with youth. And so that's what I have for us today in the way of a presentation. But before concluding it, we have tremendous thanks to extend both to our research team, as well as funders, and well as many members of the CFAR who are listed here. If I've forgot any names, I apologize, but tremendous gratitude to the CFARs for supporting this project this far, and as well as we continue to implement and analyze. So I'll stop there. Thank you all so much, and we look forward to the discussion.
Thank you very much, Nicole. And I'm going to turn it over, Nicole and Xavi, who will now participate in the Q&A. And I'm going to turn it over to Nutella to see if you could lead that part of the discussion. And I had a question or a comment somewhere along the way, if there's room and time after folks have a chance to bring up their points. So thanks for the terrific presentation, and over to you, Nutella.
No, we cannot hear you.
We aren't hearing you, Nutella.
How about now? Can you hear me now?
Perfect, thanks.
My technology, for some reason, did not like the day today. Those of you who have been in touch with children know we had a major crash of Microsoft systems, so a lot of events going on. But I wanted to start, Nicole, by congratulating you and your mentors and the team supporting your award. It's amazing work. It's fascinating. To many of us crossing the line to age, and I was listening to your presentation thinking, well, some of these teams start emerging in our lives, and those of us who have dealt with our elder parents across different global settings, being myself an immigrant first generation in the US, but also knowing American colleagues. I see Alan is smiling. We have started coming across these issues here as well. To me, it was incredible, humbling to listen to you and to realize, despite the huge socioeconomical differences, there are a lot of common themes with what I think our societies experience as well. And actually, I wanted to start a comment by saying that I do think this research is not only critically important for you and for the team that leads the research in South African settings, but it's critically important for US settings, for example, being DC CFAR home to our award, because I don't think we are doing well enough in the society supporting, even with all resources and funding and other support we have, and being a very wealthy country. I think a lot of the teams you highlighted emerges the gaps in our model of care for elderly as well in the societal level. So crucially important research, not only for resource limited settings where you've done it, but I think across the globe. And I am very happy to address the questions. I see people on the list of the speakers. So what I will ask for people, I know you mentioned you have a question already as well. Julie, maybe we just, please put the sign, raise your hand, or physically raise your hand. I will go through all the attendees in order, and we'll go back to questions. I think my first point and question, I already see two, would be very brief comment, Nicole. One thing that you have not spoken that much about is one difference between South Africa settings with other African countries. Do you plan, or are there any collaborations that you are thinking of to take this line of research to the countries with a different infrastructure, different national makeup, different size countries, different traditional settings? Because I think it's crucially important. Another question which kind of point to raise, and then I will propose that we go and have two other people speak. Is that okay with you, that we go to like cluster of 3 questions? Are you comfortable with that? So my other point before I pass the word was to focus on the distances, because I think one of the biggest issue in overall healthcare delivery and the models of support in African settings across all countries are the distances that need to be covered. We are much more densely populated. If you look, for example, at the Western European model of caring for elderly, which I think is one of the most progressive one in the world, looking at the countries like Netherlands, looking at the countries like Nordic countries, etc., they are much more densely populated. Therefore, capacity to organize all kind of services is there. And how do you think distances that need to be covered for accessing different populations in Africa will potentially influence your research? These are just 2 points from me. And now that I see hands, let me move on. I didn't see in which order, so I will just give Marta and Rachel the next 2 rounds of presenting questions, then we'll make a break so Nicole can answer. Marta, go ahead, please, speak up.
Hi, thank you so much for the opportunity. This was really interesting. And of course, I'm also an immigrant and I'm from Zambia and I've visited South Africa before. One of the things that I didn't hear come out, which is a concern here in the US and would be different in Africa generally, is the idea of elder care in what do you call them here? The housing for elder care. I'm blanking.
Mhm.
The homes where older people tend to be taken, whereas in our African culture, they're taken care of at home. And so you raised the issue of home-based care. I heard a little bit about that, but I didn't quite hear, because one of the things that is sort of a point of concern here is transitioning older adults into the homes, which I cannot remember their names, but that it would really be helpful to have homes that can accommodate older people living with HIV. And in Africa, where they're just taken care of in homes, I heard you mention home-based care, but I didn't really hear you mention sort of a setting of how older people are taken care of, especially when they have HIV.
Thank you, Marta. I think you meant retirement community or retirement homes, right? So yeah, I agree with you. So just to help on terminology, I had to learn it too. And just to echo, I also come from culture where this did not exist, and actually culturally are not very well accepted. It is almost viewed negatively as abandonment of your elderly if you place them in a institutionalized setting. So it's really interesting to hear your comments, Nicole. Agree, Marta. Thank you. Great question. Next is Rachel, and then we'll take a break. Rachel, please.
Hi, everyone. Hi, Nicole. Thank you for such a great presentation and so excited to hear about the additional funding. That's great. I have two sort of, I guess, questions, comments with particular reference to, well, I guess one is with particular reference to the US, but the first more general thing, and I think this is a question I've asked you before since you've been working with older adults in South Africa for a while, but how do you sort of parse out what's unique about the complaint that, you know, like we can't rely on the youth of today? Like, I feel like this is a common refrain among older generations. And so how do you position that? And, you know, and I think you've set your research up in a way to sort of take the pieces from it, but just, yeah, I would be interested in your reflection on that, because yes, the older people in the, you know, sort of, oh, the youth just aren't what they used to be and so on. Go ahead.
I said I say that sometimes too.
Yeah, well, no, exactly. I mean, this is such a fascinating intergenerational project in that regard, because you're trying to look at setting up the structure so that you can cross the generational boundaries.
Right.
My other sort of more observation is about, or what you know about the literature from the US setting in terms of there was a shift towards paying family members for home healthcare. And I believe it has been relatively successful, actually. But the sort of darker side to it is that it essentially means that you are paying low wages to largely women family workers. And of course, it's better than not receiving any wages. But, you know, what are the broader implications in terms of setting up care work, sort of, you know, on the one hand, trying to create job opportunities, but potentially then setting up a system, you know, sort of the inequities will be there before you know it, kind of thing. So any thoughts on that?
Yeah, great. Such great questions. Thank you all. Xavier, are there questions that you want to take specifically, or if you want to start, I can kick us off.
I mean, I just wanted to talk maybe, I mean, the distances, I wanted just to mention, we did a study on healthcare use and distances in the study site, and we didn't see that it was impacting HIV treatment in the whole population. What is true is that this older population cannot walk to the clinics. The clinics, even if we have 7 clinics or health facilities in the study site, walking to the closer one could be very easily like 1 hour walk for another person. Then that's not a possibility that will affect for sure the treatment or not receiving treatment. And that's one of the things that we want to explore. That's one of the issues why we think that young people can help older people to get the treatments at home. We have the home-based care organizations that also want to bring the care to the houses to this older population, and also with the transport, accompany them with the transport to the clinics when they can receive the treatment. There is a new, I mean, it's like 2 years ago that it was introduced a system where people with chronic conditions can go to closer places like pharmacies or specific points in the community to receive treatment. But even with that, they will need the help from someone to receive this treatment. And I just wanted, I mean, very quickly to go, and then I leave you, Nicole, but on the elder or retirement housing, it's true that traditionally the community take care, the family take care of the older population, and it is still happening in most of the cases. We have one retirement house in one of the villages, but it's very expensive, and it's only most of the people that are there are people with dementia and people that are actually outside from the study site and that are receiving care there. And then the issue here is that we need to find ways that people receive treatment at home. We have an increased number of older, especially men, living alone in the houses, and that they don't have means to get any help by paying, even if it's small wages to someone. Then they depend on what other neighbors will help. Some family will help, but I mean that's an increasing problem that we hope that the young people will fill the gap. I mean, I touched a little bit 3 questions. Nicole, if you want to continue.
It's terrific. Thank you. Yeah, and just to sort of piggyback on that, I think originally there's one old age facility that's that we knew about several years ago, and I had visited when I was last in the field. And then we learned, is the Belfast one more recent? There's another one that was developed, I think, more recently that we learned about while doing this pilot.
Mm-hmm.
Yeah. I can't. I think that's right. I may have gotten the fact wrong, but the bottom line is we know there's 2 in the study area, and both of those facilities we plan to interview people as key informants as part of the R21. So old age homes are part of the group of organizations that we plan to learn more from, and when we conduct this work. Okay, so I'm trying to go down the list of what's been addressed. So Rachel, you had asked about the parsing out of the complaint of the youth of today, and I think I might have mentioned as I was presenting this as well that you know those of us kind of doing the work in this area. I mean, folks have written about this too. There's always that tension, this sort of nostalgia for the past, and this intergenerational tension that kind of comes up when when one group is sort of talking about the other one. And I think in some ways there's something unique about the South African context, that's specific to sort of, to use demographer language, like, period and kind of cohort effects because of, the timing of the end of apartheid, the beginning of, the introduction of, democratic governance, and that very much changed opportunities for people. Which also meant that, young people today are growing up with opportunities that were just absolutely unavailable to their grandparents, and freedoms that maybe weren't, that obviously weren't as available as well. And the timing of the HIV epidemic also coincided with the timing of the end of apartheid. And so sometimes, those two kind of parallel processes aren't necessarily, separated when people talk about, well, now we've got all these young people with all these freedoms, and we also have this, like, this epidemic of HIV. So I think, like I said, so I think there's some things that are unique to South Africa in that regard, but I think this, and then I think there's things that are general to research when you ask people to, reflect on the past and you ask older people to talk about the younger generation. But I think in the terms of in terms of parsing this out practically with field work, and I think this is a lesson for, something we're planning to do and something that I think you could move, take across any context where you're studying this is, to ask people explicitly, well, if you were to write a job ad for what this might look like, what qualities would you want, and how can we ensure that, we're recruiting kind of a cadre of young people that you believe, would be the best suited for this work. And one thing Xavi and I were talking about just the other day was, maybe we need something like, and we can talk to folks in the, in public officials and NGOs as well about this, like some type of training certificate to actually, to actually kind of, to make this position look something like this caregiving position to look something more legitimate, I don't know if that answers your question. I know it's a bigger question, but I think there are kind of ways practically that we're trying to think about how we can move from general concerns and anxieties about youth to actually something that is in practice not as not as sort of overwhelming and so forth. So you had also asked about the literature from the US on home health care, and I apologize, but I wasn't exactly sure how you were thinking about the question, if you wanted to clarify.
It was not very clear. It was more of an observation, just in terms of, I think it is an interesting point in terms of learning about how that's been successful in other contexts, which I don't know that literature in particular. So certainly if you had anything to say generally about it, but then also just thinking about some of the potential downsides of setting up this type of model of paying people for in-home care in terms of, does it solidify or reify gender-based caregiving roles in potentially negative ways? I think that would be a slightly more articulate version.
No. Well, I think one thing we're learning from our data is that, even though I think there's sort of these age and gender-based notions about what's appropriate and for whom, the fact is there's still roles, there's still possibilities, right? Whether they're internal or external to the household. And, this could also be an opportunity to, to think about caregiving in a broader sense. That's not just about what we can do, within the walls of the home as well, because there are tasks that, involve external engagement, transportation, for example, to and from a clinic, that all sort of fall under the purview of caregiving. So I think there's ways we could repackage, our concepts of caregiving, to kind of extend beyond these sort of notions that they're purely domestic. And I think that the idea is that we're getting from participants as well is that there's actually a range of things that we can that caregiving, there's a range of ways that we can conceive of caregiving and help and support. And that's those types of more concrete tasks were some of the things we were trying to get at. Even the literacy is a great example as well, right? Getting someone to read medication instructions or interpret medication instructions, or retrieve medications. And so I think, I think I can see your point about the potential to sort of reify gender norms, but I also think if we rethink what caregiving and support looks like, we can also redefine those ideas as well. Perhaps.
Nicole, and if you want to take, we have 3 more minutes left. If you want to take another question, or is there any still unanswered points you have? Because I think between two of you with Francesca, Xavier, we heard quite more answers. I see 3 more hands. If I may ask people, just do extremely short questions. So I respect everyone's raised hand, and we will go with very short answers, Nicole, given the timeline. 3 minutes left. Alan, I will start with you, move to David and Julie, and please try to be brief.
I'll just make a quick comment then and just thank Nicole for a great presentation. I have lots of questions. I was struck, like Nutella, about the commonalities of the humanness of across the cultures I felt myself and some of my friends sitting on chairs answering your questions, or having some of those people in our living room having the same discussions across cultures, and it's just so the multi complexity of these issues, the aging population, the increasing chronic diseases, especially the increase in neurocognitive disease. And when you couple that in so many countries with a plunging birth rate, you don't even have that many young people to go around to provide care. I do think you have an opportunity in Africa where there's still, fortunately, is a robust birth rate, that there may be opportunities to study exactly what we're studying. So congratulations, I look forward to a follow-up conversation.
Thanks, Alan.
Thank you,
Thank you.
Alan. David, please.
Yeah, David Chang from the NIH Office of AIDS Research. I want to just comment, this work has been really impressive. The pilot work is really innovative as well. I like the idea of giving the youth an incentive, right? And you'd mentioned giving them perhaps a training certificate, but perhaps also trying to think about more sustainability. Youth may get burned out. I mean, people who take care of older people and caregivers in general get burned out over time. But perhaps youth who might have a vested interest, maybe in a track to nursing or healthcare in general, might be a better focused population to stay, because there's a vested interest. There's more of a win-win in that sort. I know that's hard to do in this design and probably in this R21, but just something to think about for the sustainability and prevention of burnout for young people.
Thank you, David. And moving to Julie.
Thanks so much. So thanks, Nicole. As I was listening to you present, so I have a kind of a reflection and a question. I'm trying to make it brief. I was reminded of another study, an implementation science study that some of my colleagues at the Population Council conducted some years ago, focused on youth caregiving. And it wasn't focused on older populations per se, but it was youth caregiving, home-based care earlier on in the epidemic, excuse me, so that they were bringing it was home-based care led by youth. And one of the very positives that came out of that study was a reduction in stigma, in community-based stigma, where at that time, many people were isolated, weren't being visited anymore. There was a great deal of stigma. Now, the issue of stigma did not come up much in what you presented, particularly in the context of HIV. So I wondered if you could reflect a little more about the role of stigma here around HIV, if any. And I'm also happy to share any findings from that example in Zambia, as you're thinking about developing activities with youth in South Africa. Thanks.
Thank you. Xavier, do you want to take a first?
I just want to give a very quick point to each of the new aging situation. I think that this is an important thing. It's happening in all the countries, and it's happening in Africa, and it's happening all over African countries. And then we now have to start responding to this situation and this new epidemic of HIV, chronic conditions, dementia, all happening at the same time, and how the health systems will respond to that. I agree that we have to avoid the burnout of young people, and there is a network. I mean, I think that's what we are trying to present. There's a network of services that we want to explore with the key informants from the clinics, from the caregivers in the homes, from the youth, what the youth can do, and how we can help build a structure around these new needs. And I mean, it will be interesting to see about the stigma situation of Zambia, what was discovered there, what was found there, and what can be applied. Thank you.
Nicole, do you want to add anything before?
I'm mindful of time. So I think we can probably leave it there. I mean, I can go on and I could say a lot about the stigma question. So perhaps Julie and you and I can chat more about it. I'd be interested as well to learn about what happened from Zambia. But I feel like, I mean, Xavier and I have been working on these issues for for a while now with another study with the HIV 40 R01, Sonia Majola, the PI for. And, I think that I think we'll learn more about the stigma question when we talk individually to people as well. But I think a general sense from the community is that really HIV is easier to manage than other chronic conditions that they're facing. And that disclosure is higher. We've seen, certainly within families. But what it actually means then in the context of thinking about a caregiver external to your family is a really important question that we need to consider, and we will explore with the work.
Thank you, Nicole. And I just wanted to make sure we pay tribute to a very valuable comment by David, because I do think that you alluded to that in your presentation, that the next step would be to gather, use desire and disposition to do this kind of care. It's not the coolest thing. And just to add to David's comment about the incentive role, I think it's very important, but I think to today's generation, incentive is not enough, and making it cool on social media will be another very important element. So I think as you develop your research, one of the thoughts crossed my mind: how can you make this a positive image on the social media among young people that would be attractive? Because we know that today this is frequently even a bigger part of their lives, rather even compared to financial sustainability and incentives. So just wanted to acknowledge this very valuable point of how to take it practically forward. It looks like you start doing this work. Congratulations to you, Nicole, again, fantastic. You can see excellent questions. I think you saw a lot of people, if you watch the people listening to you, which I did, people were taking notes. I want to acknowledge also very rich questions. Very rich questions and rich comments. Marta left a couple of very insightful comments online in addition to her question. And Rachel, that was not a very long question. It was a very valuable question, because I was also asking myself, I heard a lot, and Alan alluded, we're hearing a lot in the community, people shifting care of elderly to homes. It's happening in the US. So I think that is a very relevant question. Together, I want to thank you both for doing fantastic presentation. Xavier, thank you for dialing in with all the support to Nicole on her studies, and also answering questions with very insightful feedback. It's been a fantastic session. I learned a tons. I wish you a lot of success. And I do want to encourage, on behalf of Julie, myself, and Khadija from the Global SIG and CFAR, if you are interested in continuing these collaborations with Nicole and Xavier, if there is a model that any of the people who were online today want to expand, build, take to other countries, do mutual studies, link it to the communities in US, please reach out. Please reach out to Vivian. We can put you in touch. We can help you schedule calls. We can come on these calls as consultants. You can choose different collaborators. So please take this also as a call to take forward. If this is a topic of interest, and Nicole and Xavier make it, I think you made it of interest to everyone. I'm on a pediatric adolescent, and I was like, should I switch my research to elderly? This is a lot of fun. Interesting questions, fun from point of view of a lot of unanswered challenges. So thank you again very, very much. Thank you all for taking your time. I know we're a few minutes over the time. Thank you for those who stayed. And there's a question, will the slides be available? That's the last question from Jules.
I can talk to Vivian.
Okay,
Yes,
we will probably make some of the slides available to attendees of the workshop with your permission, obviously, or whatever you want to share with us. If there are some slides that need to be removed because they're unpublished, we will understand. Thank you everyone again. And
so much.
Go ahead, Nicole.
No, I just wanted to thank you all so much for the questions and the interest. And just to say that while this is specific, the study is specific to South Africa, it really is our hope that the lessons will be something that can be, applied and explored in other settings as well. So we definitely see the significance beyond our context as well.
For sure. And you made us all think about it today. So again, congratulations. Thank you all for attending. Thank you for those who stayed over time. Until next Global SIG webinar. And if there's any business in between, do not hesitate to reach out to any of us, myself, Julie, Vivian, or Khadija. We are here for you to support you. Thank you, Nicole and Xavier. Thanks. Bye, everyone.
Thank you so much.
Thank you.
Bye.